You're listening to the Patient Advocacy Now podcast, presented by Greater National Advocates.
It's just gut-wrenching sometimes. Like, if it's sad and they're crying, I might cry.
Amazing how many doctors do not even want to treat somebody who has Medicaid.
Medical system is about making money.
And I said, so are you hiring more nurses, or you're just telling each nurse to work harder?
Dr. Sherika Newman, thank you so much for being on the podcast.
Thanks for having me.
Why don't you tell everybody who you are, what it is you do, how you got into it, just to start things off?
Awesome sauce. So I am Dr. Sherika Newman. I actually am a hospice and palliative medicine physician that has been doing patient advocacy my whole career, really, but I formalized it probably like a year or so ago. And I formed Doctor in the Family, which is the name of my company, after one of my friends called me and asked me a medical question. And I was like, oh, wouldn't it be cool if everyone had a doctor in their family, right? That they could just call and ask questions. And that's how we came up with the name Doctor in the Family. And we initially started as concierge services for palliative care, and we morphed it into patient advocacy once I realized that I was doing it anyway and people really needed me in that lane. And so now we launched a full patient advocacy service. And so we do patient advocacy and weight management. And our weight management arm was birthed out of our patient advocacy arm because my patients were saying, please, please, please figure out how to do this for us. And I was like, well, I kind of don't do that. And they're like, yeah, but we trust you to do it and that you're going to do it the right way. And so I learned about obesity medicine and started studying it and started a weight management practice.
Talk to me about the obesity. We'll get back to palliative care because I'm fascinated by that as well. You know, there's a lot of murky waters around weight management right now, and people don't know what's safe, what's not, how to get it, how not to get it, and what realistic expectations are. Tell me what you uncovered because it was new for you. Tell me about that journey and what you learned along the way.
Well, what's very interesting is what I quickly learned, John, is that the truth is most of us, many doctors, were not trained in how to really manage obesity or weight management at all, and the science behind it. And so the more I delve into it, I got into the science behind it, and that obesity is really a chronic inflammatory state. It's a disease of the brain, like the central organ system. And it really is not about willpower. It has nothing to do with willpower, even though for years we've been telling patients to eat less and exercise, right? It's more than that. And that's what I've come to appreciate it. And I had been prescribing weight management meds in the past, but I didn't like them and I wasn't really keen on them. So I would prescribe lifestyle modifications to my patients. And most people would fail. But the GLP-1s are groundbreaking, and they are very successful, not just in the making you feel full, early satiety part, but the whole brain part that goes along with it, meaning the food noise, the reward system, because obesity is a chronic disease. And if we treat it as such, like we do all the other chronic diseases, right? We do lifestyle modification and management for high blood pressure. We do lifestyle management and medicine for diabetes. We do lifestyle management and medication for asthma. Obesity is the same. And I think the shame around obesity and weight bias is really the big problem. It's more than just medicine. It's a cultural problem. And that's why people are a little gun shy about starting the medicine, or am I going to do it right? Am I going to have Ozempic face or Ozempic body, blah, blah, blah. You know, they have all these names behind it. And there is a lot of misinformation. And so I think it's so important for people to talk with your doctor, the person you trust, or a doctor that does obesity medicine so that you can get credible information and decide if it's right for you, right? Because it's more than just weight loss. We want health, and most doctors are there to partner with you on your health, not just you losing weight.
You said a term that I hadn't heard before, food noise. What do you mean by food noise?
So I'm so glad you asked, because John, I had never heard of it before either. So Food noise, and maybe because I'm going to out myself, okay, John? I've always been skinny. I've never had a weight management problem. So to be a weight management doctor, never had the problem, I had to learn a lot. Food noise is that dialogue that patients that struggle with obesity or overweight have with food, right? Did I eat? Should I not? Should I eat the one more donut? Should I not eat the one more donut? Should I eat the carbs? Not eat the carbs? Do I need an extra salad? No. That thing is food noise. And a lot of people that struggle with obesity talk about the food noise, the constant dialogue they are having with food. And it is a syndrome, I guess, or a part that's very indicative to people that have this disease process. And it's something that if you don't have the disease process, you're unaware of. Well, what we have learned is that this medication, the GLP-1s, reduce food noise. So there's no longer that dialogue that they're having with food. And I think a lot of my patients love that part of it more than anything else because it is very consuming to have this constant noise and narrative in the back of your head, and it makes you feel defeated is what they explained to me. So you're in this conversation and it feels like you keep losing because you're eating the donuts, right? It feels like you're losing because you're taking the extra slice of pizza. And so then the noise becomes, oh man, you ate that slice of pizza. This is why you can't lose the weight. This is why you keep failing, blah, blah, blah. It becomes that thing. And it kind of doubled down on, I don't have willpower, instead of obesity is nothing to do with willpower. So having that dialogue and you keep feeling just as like, man, I suck at willpower, and that's not the truth.
So, how does the GLP-1 help with the food noise? Because the way you're describing it, it's mental. I'll be honest, I don't know much about it as a biologic. Are you saying that it actually affects the brain chemistry in some way, or is it that it's creating a sense of satiation where the food noise just doesn't have a chance to latch on?
So the reason why obesity has been classified in the central nervous system is because it is a disease of your brain. It's a reward system. So just like any other addictive issue, becomes about the reward in your brain saying, oh, I'm being rewarded for this, I'm going to keep doing it. That's where the food noise comes in. And what we know is the GLP-1s stops that feedback system. So it has a place in your gut, right? Like it does cause early satiety, and that plays a part in this loop too. But it also is an independent feedback of the noise and the reward system that is a part of this disease process.
That's so fascinating. You hear everybody talk about Manjaro and Ozempic, but nobody talks about this, not unless you're getting really in the weeds with the research or into the podcast. But of all, I mean, I live in Los Angeles, and I think you throw a stone, you'll hit 6 people on Ozempic, and nobody talks about this.
And that's why I said, to me, this is the most rewarding component that my patients have reported to me. And I think if you can manage this, even when you're off the meds, if you're more aware of it, even when you come off the meds, some of my patients has been successful in still dialing back the noise of it because now your brain has almost rewired or reset itself. And that I can't imagine having that as a constant all the time in the back of my head and then having it shut off. That has got to feel good.
Yeah. Yeah, I can imagine so. So what is your role as an advocate for weight management? Or do those people actually become patients? What's the
Well, it's
differentiation?
too
You are a physician.
interesting. It's interesting. My weight management service line was birthed out of my advocacy, right? Like my patients were like, we want to be on this medicine. We want to do it right. We're scared of all the bad things we're hearing, but we trust that you're going to get it right. Like, so we need you to do this for us. Like we really, really need. And remember, I had a concierge practice, right? So a lot of these patients came out of my concierge practice, and I was already intimately involved with their health care. And they're like, we just need this piece from you because we've been struggling with this. So it's two separate arms, but it was birthed out of it. And I think I love the fact that it was organic like that, John, because it just speaks to how people want you to advocate for them when they trust you, when they rely on you, when they, are like, we know that you're going to do this properly. And they knew. I've looked at the genetics. We now have a way to test your genes to see, if you basically have a propensity for it. And then we have one college that went for it and broke it up into 4 different types. The 4 different types are hungry brain, right? That reward system in your brain.
Mm-hmm.
Um, hungry gut, meaning that not being ever feeling full. Emotional eaters, meaning my reward system is soothing my emotional distress. And then the slow burners. So I literally looked at your genes and they can tell you which category you fall in. And then we can tailor your medical treatment, right? The lifestyle and the medicine around which category you fall in. And the GLP-1s are effective for the hungry gut. They're most effective for hungry gut. And over 60% of people are hungry gut. That's why they're widespread being effective, because that's the group most of us fall into. I'm even hungry gut. I just never, I guess, listened to my gut, or it never activated all the way, right? But because most of us fall in that category, the GLP-1s have been effective. So because my patients knew I would advocate in this way and make sure I've checked off all the boxes, I can own the fact that I'm fastidious, checked off all the boxes to make sure we're doing this properly. So you get the results you want and, don't get the results you don't want. And it's healthy. And so what we came up with is this life med journey, which is a combination of lifestyle modification plus medicine combined together. And it is a journey. And I feel like whether you're struggling with obesity or overweight or not, you're still on this life med journey. You're still on this. Every one of us, no matter what your plight is, we have to combine lifestyle and medicine to be our best selves.
So are your, just so I'm clear, because it sounds like, so they were patients and then you had to do the advocacy work in terms of the research. But are you then still treating these people as patients, or do people come?
Yeah, so some of them switched over to strictly on the life med journey, which is our weight management. And then some of them still need my advocacy in certain forms. So it's 2 different service lines under one practice.
Gotcha.
So I do both. I have 2 hats. I have an advocacy hat and a weight management hat.
So what does the advocacy hat do outside of the weight management? Let's transition into that.
Okay, so it's independent of weight management. Our patient advocacy service works with patients, their families, and their medical team to ensure that patients are heard, seen, and validated inside of every single medical encounter to get better health outcomes. And we know by research that works. People get better outcomes when they can advocate, either self-advocate or bring an advocate.
And what does that look like on a day-to-day basis? Are you reviewing case notes with them, or like looking at their charts? Are you interviewing them and asking them how their experience is? Are you prepping them before the doctor's appointment? What does that look like in your practice? Because one thing I've learned, okay.
All of that. I mean, I didn't even pay you. But it looks like all of that. It really looks like this is, years of palliative care. I have the skill set of being able to ascertain what you need and then build a service line around it, right? And I was a teacher before I became a doctor. So what I do is I talk with patients or their family, and I kind of get an understanding of what they're looking for. And then I'll tailor the treatment to that. So whether it's appointment prep, where I prep you for the appointment, whether it's chart review, or review your chart and I'll say, hey, I agree with your doctor. I don't agree. You might want to ask them this, ask them that. We do that. We do bedside monitoring, where I've been at bedside with patients and their families, there to talk with the doctors in real time and do like peer-to-peer collaborations. And all this is collaborative. I've been video conference on phones, telephone, on the phone into appointments. 3-way in order to be a part of a patient appointment. So it just depends on the level of service that the patient needs me to advocate as. And then we just, because of my son, built out this thing called quick question appointments. It's better than going to like Google or Chat GPT. If you have a quick question you want to ask a doctor, then just you can get a quick question appointment. And it happened because my son's friend went to the ER. She was given medicine. They didn't have the medicine. She didn't know what to do. And it was just like a quick, hey, son, have her do this, this, and this. And he was like, Mom, I think you should offer this in your advocacy line, because sometimes people just want, like, they just are lost in the system, right? And they just need something quick to point and direct them. And so we opened up quick question appointments recently. And so it's just at the level people need, because not everyone needs the same thing or the same intensity. Most of the time, it's a serious illness and we get involved at the beginning and it's a lot of services. But then as we move forward, you need less and less advocacy. And I'm pretty big on teaching people to self-advocate too.
Yeah. That quick question appointment, I think, kind of resonated with the name of your company, Doctor in the Family, because that's kind of, I imagine someone being in the ER going, I should text my dad if your dad was the physician. And so that's kind of what you're talking about in that regard, at least from what I can gather.
Correct. And I think people, I mean, honestly, the healthcare system can be very complex. I mean, the jargon, the navigation, the medicines, it all can just get very overwhelming to people. And a lot of times I tell people that's what I feel like I'm solving is overwhelm more than anything else. And so if you could get a doctor on the phone to say, hey, I'm in the ER, this is what's going on. Is there something I need to be asking or not asking? Or, what should I tell them? Should I not tell them this? I think that just eases people and makes them feel educated in the moment, and then the overwhelm gets kind of dissipated and they get calmer. And that's what I have a lot of times that happens.
A lot of our advocates that we talk to on this podcast are not physicians. I would say most advocates are not physicians. They're either nurses or sometimes they come from insurance, or even they were just somebody's family member and their own personal advocate, and then started figuring out they became board certified or started doing it through other routes. What do you think separates having a physician as an advocate other than just their knowledge? Like, so when you say you go bedside, so you do peer-to-peer coordination with other doctors, how is that different as a physician than having a nurse advocate?
Well, I think it's the language we talk, right? So doc to doc, there's a way we can just vibe and do the dance together, right? There's this just harmony that happens when we converse with each other compared to other disciplines. We both are kind of trained in the same vein. So we kind of know what each other's saying without fully saying it. And having the ability to do that differs from any other advocate. And then my ability of doing palliative care all the years, I can then flip to the patient and family and almost like translate it into a way they understand, but also help them build the care plan that matches who they are. Because what people really want in the advocate is help me align this massive construct and this overwhelm into match who I am. And everyone is unique, right? And some of my patients struggle to have that dialogue with their family. Some of them struggle to have it with themselves, like making sense of all of this and how it fits with me as a patient. And so my ability to do that on the doctor level, it kind of moves a little bit probably quicker, because as doctors, it's easier for them to pick up the phone and run it down to me quickly because everything moves quick in medicine. It's easy for them to run it down to me quickly and then me take the time to kind of translate it to the patients and families, where I don't feel like we can do that across every discipline.
Sure. That makes perfect sense.
Mhm.
Tell me how you got into palliative and hospice work to begin with.
Oh my God, Mrs. Youngblood. Mrs. Youngblood. You never forget these things. I had this patient, uh, Miss Youngblood, that I had as an internship, and it's our first year out of medical school, right? So as an intern, I'm on call every fourth day. And I swear, John, I was just trying not to kill someone, right? Because you're just out of medical school and you don't know anything, right? You're not dumb. You're like, I don't know anything. I just don't want to kill somebody. And this young blood had these brain lesions. She was in her 70s. And she said, I don't want to do all this stuff. We wanted to biopsy her brain, which means we had to drill through her skull. She was like, no, 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 thanks, no parts. I've lived a wonderful life. She had her horses and she was like, I'm good. And she asked to go to hospice. And so as an intern, I was like, okay, this is what she wants. How do we make it happen? And I learned, how to write a hospice order. Well, a couple of days go by and Miss Youngblood starts getting better, which is like not unheard of on hospice, right? So I get a call from her daughter, and to this day, I still don't know why she called the intern back. Seriously, I'm like, how did she call me? But obviously, I formed this relationship, and I go down to hospice. It is like in the recesses of the hospital, through supplies, through engineering. I honestly thought someone was punking me, but I did. I finally arrived at the hospice unit, and it's beautiful. It was like an oasis in the desert. It was such a beautiful unit, stained glass windows at the end of the hall. I was like, I want to work here. So I got on the phone and I talked with the daughter, and I had seen my Miss Youngblood, and I said, well, she's still sick though. Like she still doesn't want anything done. She is physically better, but she doesn't want anything done. And I just had an organic conversation. And the hospice nurse, when I hung up, said, have you ever thought about doing this? And I said, as a matter of fact, I just thought about it when I walked through the door. And that's how I got introduced to hospice. I had no idea what it was before Miss Youngblood. Didn't even know it existed. And I started doing extra rotations in it. And I really found that it was who I naturally was. Just naturally, I enjoyed that type of practice and that type of medicine. So I became a hospice and palliative medicine doctor because of Miss Youngblood.
I think that what the nurse saw in you in answering that call and taking the time and having the compassion to speak to them not only made you kind of bred and groomed for hospice, but naturally also made it an easy way to kind of get into advocacy work, because that's the kind of patience and compassion that I keep hearing from advocates again and again. And it's very different in the hospice and palliative world than it would be in plastics or in sports medicine, where things go, 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 and you're talking to only one person. I mean, especially with hospice and palliative work, you're talking to the whole family a lot of the time. You're explaining things. You're kind of quarterbacking the person's journey. And it's so interesting that somehow it ended up in weight management as well, but that's where it just led you.
I say the same thing. It's just very interesting. Like I have two different arms of my practice that one birthed the other one, but it's all around, compassion for the human experience and putting the human first, no matter what framework it's in, knowing that patient-centered care and humanity is at the crux of it all. I just left the Healthcare Advocate Summit. It was my first year there. And like you said, there's so many different types of advocates, right?
Mm-hmm.
But what I took away from that conference, I mean, besides Melissa and Elizabeth, that's phenomenal at the conference. I mean, the way they put this together was phenomenal. What I took away is that at the center of it, these are thousands of people at a conference who really care about other people, who really care about humanity. Whether it's fighting on the billing arm, whether it's fighting at the patient level, at the system level, they really care that people receive good care in our healthcare system, in our construct. And to be at a place where you have a unified mindset like that is refreshing, especially as a doctor, because I only see one scope a lot of the times, and that's inside of the healthcare system, like inside of the building, inside of the encounter, inside of the rooms.
Right.
But being able to talk to people who do it from the billing arm, who do it from the social work arm, who do it from the home arm, going to people's homes, and IT, like I met IT people and Hollywood people who came out of the movie industry and have done it from that arm. I mean, being able to see that with the same mindset of we really want to make sure people are getting good health care, that's refreshing.
How do you balance it all? It seems like you got your hand in a lot of pies and you probably have a pretty significant caseload. How do you manage to stay sane, serve your patients, your clients, and not feel completely burned out and kind of spread too thin?
I guess I've been doing it a while, so I know went to hit the pause button. One, I take Mondays off. I've been very intentional about taking Mondays off. And I get help when I need it. So I lean in on my team when I need it. But when I need to replenish Sherika, I know the things that replenish me. I've been doing hospice and palliative medicine over 10 years, and that is a very emotionally laden job in and of itself. So I figured out the things that replenish Sherika. And it can be simple things like some days I just need to sit in a tub of water. Some days I need to phone a friend. So it just can be a variety of things, right? Some days I need to run a case by a colleague because I'm stuck. And I think owning the fact that I need help was probably the biggest rate limiting step, especially as a physician. We're taught to know everything and be all things to all people. And so knowing that you're going to need help and calling it, phoning it in or asking for it was probably the biggest hurdle for me early in my career. But once I figured that part out, I was like, there's no sense in going back now. Right. And so I because I enjoy doing this, it fuels me too. But then I know the line where I need to stop and kind of replenish myself. And I make sure I do that for myself. And then, of course, Christine, my assistant, she'll block time for me. I don't know if you ever read the book Deep Work. But he talks about blocking time on your schedule for deep work. And so I do that too. I'm intentional about blocking time so that you're focused on something and not pushed all over, so that then when I come out, I can do multiple things because I've already processed it through and now it's just working it, right? Um, and stuff like that. So I've over the years developed what balance looks like for me, um, and the grand scheme of things, I guess.
Yeah. Where are you located, and how much of your practice is virtual versus in person with your clients?
So I am located in Atlanta, Georgia. And I would say 90% of my practice is virtual, including the weight management, because I wanted things to be convenient for patients and families. And so most of it is virtual. And then if I need to be on site, I've flown to Florida to be at bedside with patients. Of course, I've been bedside in Georgia um, with patients. So it just depends on kind of what's needed still. But about 90%, if not more, is virtual. Um, because I think in the society we live in now, making it as convenient as possible is invaluable because all of us are doing 500 things. And what I've come to appreciate down through the years is having one more appointment or one more of anything, especially when you're seriously ill or struggling with something, can in and of itself feel overwhelming. So making it convenient where you don't have to leave your house, you can do it any place but your car, like you can't be driving and talk to me and see me, but almost any place else, yeah. We can just hop on the phone. I'm literally like a phone call away, and I wanted it to be that easy for patients, or a video call away. I have some patients that video me at any time. It's like a FaceTime video. It's like they're like, I don't mean to bother you. I'm like, no, it's fine, because that's how I set up my practice. I really wanted that convenient for patients.
Wow. And you mentioned Florida. Do you find that you have a significant amount of your clientele that's out of state?
No, not a significant amount. I used to practice in Florida, so I still have some patients there. I'm a native Floridian, and that's where I started my initial practice. So I still have some patients there that um, I guess rely on me and trust me. So of course I feel honored.
Trust is not something to be undersold. It's once you trust somebody, it's hard to walk away from that, for sure.
And I am honored that they, trust me. I always tell my patients, I know that I went to school to do this, but I do. I always feel honored that people would select me to assist them in whatever way and would trust me enough to do that. I do think that it's an honor because it's lots of doctors. People get to choose what they want and who they get to be in this intimate space with and vulnerable space, because being a patient is a pretty vulnerable place to be, and pretty intimate space. And so the fact that they would let me into their intimate space is honorable to me. So I have some people in Florida, but the majority of my practice is in Georgia.
Gotcha. Do you see things about the medical and the healthcare system, either as an advocate or as a doctor, that you feel are broken or that you wish could be easier for the patients? If so, what are they?
Well, of course, I definitely feel like some things are not patient friendly or patient focused. And I fortunately also feel like we're moving more away from it. Just as we grow in the healthcare industry, as we see new programs coming down the pipeline, I think they're all well meaning, well intended, but it doesn't always end up being patient focused or patient centered. And I know we can't be all things to all people and fix everyone's problem, but I do wish that there was a way we could be more patient centric. And I keep saying to my colleagues, I even said this at the summit, I feel like self advocacy is the key to equity because I don't think the system can give us equitable care. It's too many people to be equitable, right? Not even equal. You can't even get equality out of it. But I think you being able to speak up for yourself and speak for yourself or having someone give the ability of someone else to speak for you and on your behalf is how we're going to balance off health equity, because what John needs and what Sherika's need is different, right? But having someone, if Sherika and John can't do it for themselves, to say it is one thing, but how to do it, I think a lot of people are scared to do it for themselves or don't know how to do it for themselves. They come from a shy family or quiet family, they're introvert, whatever the barrier is. And I feel like that is going to widen as things progress in healthcare because the numbers are growing, the need is growing, the baby boomers are getting older. And if you're not speaking up for yourself, the squeakiest wheel get the oil. If you're not doing that, then you could very well unintentionally end up with bad care. And that saddens me as a physician. It saddens me when people come into the healthcare system in late stage disease because they just didn't know how to get the help. Or I recently heard about a story where someone died because they couldn't get the medicine they need because the insurance went with the higher payment structure from $30 to $500 and the person wasn't able to get the medicine and they died. Like to me, those constructs, that is broken. That is a broken system. And how do you fix that system if the person don't know how to speak up for themselves? And it's complicated, right? If I go to the pharmacy and they say, we can't cover this medicine, me, Sherika, have the means to cover it, or at least the knowledge to say, we'll figure something else out. But there are thousands of people that don't.
Right. And they just say, okay, I guess I'm not getting my medicine.
And and then they show up to our hospitals sicker than what they needed to be. And to me, that's the brokenness of the system.
Right.
And how we fix it, I don't think it's at the system level. I think it's multifactorial. I think it's patient. I think it's provider level, and I think it's system level. And I think it's a national thing to fix it. But one thing we gotta empower people to know when to lean in and when to lean out.
Yeah. Well, if someone wants to work with you directly, what's the easiest way for them to get a hold of you in your practice?
Oh, the easiest way is twofold. One, give me a call, 404-900-8654. And also on our website, www.myditf, my doctor in the family, the acronym.com. And on the website, it has all the information about what services we offer and all the links you need to make whatever kind of appointment you want, including quick question appointments. So that's the easiest way to work with us. And you'll get Christine when you call, and she's got a breadth of knowledge about the practice. And we definitely make sure that you're in the right service line. And I actually do a lot of communicating myself. I like being intimate with my patients. So you may even get a text message from me because that's how I am. I'm the doctor in the family. That's just who I am organically.
Well, Sherika Newman, thank you so much, and I appreciate your time, and I was really enlightened. I have some more digging to do about this weight management stuff now. I mean, just the way you broke down the hungry brain, hungry gut, emotional eaters, that's going to be dinner table conversation for the next couple of weeks, I'm sure.
No problem. Shoot me over an email if you have a hard time finding anything, and I'll send you the links.
Awesome. I appreciate it. Thanks so
No
much.
problem. Thank you, John.